All, this is Dr. Mobeen Sayed from drbeen.com. Welcome to our third show for today. This is a random chit chat. We're going to talk about a bunch of things, including the audit that was going on for Dr. Bean. Okay, so welcome. Today, Rubies are red is first. Rubies, I saw you in the morning chat as well. Are you based in Europe? So Dr. Bean, Ruby Zarad is saying, Dr. Bean, could the thrombotic instances be the result of people who had COVID without knowing it and ended up with the clots that were unresolved at the time of the vaccine? So it is difficult to say that the clots may have been in outpatient-like scenarios with COVID without the remaining COVID symptoms to occur first, meaning directly going to clots is going to be a problem because the virus has to first arrive in our nose and throat, and let's say it didn't create symptoms there, then it has to go to our lungs, and let's say it didn't create symptoms there, then it has to enter blood. And most of the time, there can be tiny bit of viremia when the virus is here, but most of the time not sufficient that the larger amount of virus is present to damage the blood vessels. Normally that would happen when the virus type is such that it infects the blood cells, or the virus has caused enough damage in the lung or some other part of the tissue where enough inflammation has occurred, enough blood leakage, not blood leakage, blood vessel damage has occurred, enough cytokines are present to dilate the blood vessels, and that opens up the pores, and then enough things are exchanging between the blood fluids and the interstitial fluids that virus can easily get into the blood vessels and then do the harm there. So there must be some sort of a focus before the viral issue in the blood vessels. So for me, this will be a possibility, but difficult one without any other signs and symptoms. Steve says, first, Steve, I think today, although Steve tries to be first, Steve, I think Rubies are red was first today. Jim also says first, so maybe there were three firsts. Jim, Steve, and Rubies. DDS, hello, how are you? Gold Country, how are you? Jim, second. Jim has already adjusted his position. L, hello again, Dr. Bean and Cool Beans. Yes. Boy, I was first. Yes. Rubies, you were first. Margaret, hello, how are you? Trevor, hello. Rima, hello. Doug, hello. Did I miss anyone? Gold Country, Russ. I hope I didn't miss anyone, but now there is a huge list. So Diversity Love says, I was first, I was just politely quiet. Okay, perfect. So L says, good answer. Thank you very much. Okay, so wanted to show you something which was bothering me since this morning. I mean, nothing bad, and you are all aware of this kind of bias and seen it. But this is something that was bothering me. Check this out. This is European Medicine Agency about AstraZeneca and the thrombosis and clotting. And here I did this discussion in detail this morning. So maybe not needed to do it again. But in here, you would see that they continue to hedge one way or the other. Sometimes they say thromboembolic events are not associated. Then they go to thrombocytopenia and they say that is associated, and it's a rare thing. So they're kind of playing with the type of diseases, but these all come under clotting. And then they are going down here, and something that was interesting for the healthcare worker, they are saying the number of reported events of this thrombocytopenia and thrombosis exceed those expected, and they show that here. So for example, here, if you see, however, based on pre-COVID figures, it was calculated that less than one reported case of DIC might have been expected by 16th March among people under 50 within 14 days of receiving the vaccine, whereas 5 cases had been reported. So they're saying we were expecting one if we saw pre-COVID time, And now after the vaccination in the same group, we saw 5 where we were expecting 1. So there is a rise. Similarly, the CVST, the cerebrovascular systems thrombosis, 1.35 cases in general, and now they saw 12 cases in the vaccinated in the same group. So of course there's a rise there. And they deny it, that it has nothing to do with it. But when they talk with the healthcare professionals, they say the number of reported events exceeds those expected. And causality, although not confirmed, cannot therefore be excluded, correct? And I give it this to all of us. I am a pro-vaccine person, that the damage done by this thrombosis, the number of cases may be far less than if these 20 million people had gotten the actual infection, and the deaths over there and thrombosis over there will be far more. So I get this. But just trying to ask these agencies to be consistent in their messaging. So here they're saying this. Then if you go to ivermectin, they are saying don't use ivermectin because the side effects could increase with much higher doses. Here they don't even have they don't even have an evidence, and they're still saying, hey, don't use this thing outside of the trials. Here they have evidence, and they're saying we cannot exclude this damage is because of the vaccine, and they're still doing it. So I don't mean by this conversation to say they should not approve the vaccine. Vaccine is necessary. I would take it. I said, if there is no other vaccine, I will take AstraZeneca. But they should also not stop ivermectin. Or at least they should be consistent. If they're going to block ivermectin, then stop AstraZeneca as well, because your wordings are and assessments are very similar. So anyways, I thought that was interesting. So back here, yes, the update for the audit. So audit is finished. We have provided all the data. They had found some issues that they said were not, they were compliance things. For example, adding the, what is that? Some messaging before the videos to say no disclosures or no conflict of interest, or updating about if there is an off-label use of some drug, what will we do? Would we remove that later on or not remove that? What is a process of making sure that the content that is there is correct and accurate? And auditors were kind enough to say that if there is some content that you have uploaded that in this time looks correct, but afterwards when we look back, or there are more studies and they say it doesn't look correct, then would you remove that? And I said yes. So there were a bunch of such things. We have gone through them, and we have finally become compliant again. So that is a good news. We got our email today. So we are kind of happy that we're out of audit. So thank you very much during all of this time to support me. So having said that, Denise, you were saying that you are not feeling well. I hope you are feeling well. Take medicines and be healthy and happy. Margaret, thank you very much. Somebody said, Dr. Bean, great hair. Simple Garden says, got a haircut. Yes, I got a haircut. Rubies, I hope everyone is okay in your family. So Christina says, what agenda is it which driving the hatred for ivermectin? No profit. Yes, I think no profit, nothing else. LME Lickme says, why long haulers feel burning sensation in lungs and cold feet? Is it possible that some organs like lungs really have temperature by themselves? No, it is a sensation. It's not actually the temperature there. And that sensation is because of the irritation of the nerves over there. So it is more of a nerve irritation than actual temperature difference. Cold feet could be because of the blood circulation issues or energy level issues, but lung heat is mostly irritation. Cool Bean number 381. When do you think Novavax will be available? I am waiting for that as well. So they have to still go over the process of getting their approvals. They had said soon, but I do not know exactly when. Deborah says, Dr. Bean, call your county health department to get on a list for a vaccine. I actually have had those discussions. I am not eligible yet. I am not a practicing doctor, so I am not in healthcare staff. And my age or my I don't have comorbidities, touch wood. And then my age, none of them puts me in the list yet, which is eligible. So Machiavelli, peripheral neuropathy, yes, kind of that. And this burning sensation or sometimes cold, if cold is related to the metabolic statuses as well, but when there is the same place having burning sensation, sometimes cold and sometimes itching or sometimes numb, that is called paresthesia or abnormal sensation. So that is definitely a neurological symptoms. Nancy Camp said, you're a young bean. Yes, so far I'm a young bean, but I am getting up there. Hi, Dr. Bean. What do you know about Cuban vaccine? Seems to have the same mechanism as a Novavax vaccine. Can you talk about it, please? I can. I do not know anything off the cuff, but I would take it down. So somebody was asking about our Doug White saying, just heard Pfizer short. Should I continue with Ivermectin for a month? So my discussion with others. So let me remember that panel of doctors a few days ago that we had a discussion. In there were some doctors who were of the belief that ivermectin should be discontinued before and after the vaccine to allow the vaccine to work its magic. So I want to provide you both sides of the messages, or both kind of messages. My belief, and I did have an offline discussion with them as well to say that I think is not necessary. So my belief is that ivermectin does not cause any issue with the vaccine itself from a mechanism point of view, and even from an inflammatory tempering point of view. So I think that while you're not fully protected, ivermectin can continue. And then when you are fully protected, then it is really your call. Steve, this is really funny. I think it's called When Vaccines Go for a Job Interview. Yes. Is that a video name or is it just your? Okay, so let's see. So let me see the question. So Simple Garden has a question with a flag. I love that. Were you able to find out any information about cumulative ivermectin and clearing body system? Not yet. I didn't even get a chance. The AstraZeneca debacle started as well. My apologies. There are some folks who love AstraZeneca. They become upset with me. But I find it hilarious that AstraZeneca keeps getting themselves in trouble. The not hilarious part is the serious side effects like thrombosis and those. There are deaths with that. Although they came back and they said nothing to do with AstraZeneca, I think it is something to do with AstraZeneca. Just like over here, the person who died in Florida, the doctor, I thought that was something to do with the vaccine. But other than that, these are just weird, childish mistakes to have some data given and then the efficacy press release, and then the data board comes back and says, no, the wrong date. These things should have been discussed behind the closed doors, and the agencies should be on the same page. Why is this a soap opera right in front of all of us? So anyways, but I had to talk about this because EMA's messages, the ivermectin EMA message, and then AstraZeneca's phase 3 trial became a high priority. So Simple Garden, I would work on that. There is another high priority thing that is left, and that is to compare the serious side effects of the vaccines. And it's just, even after doing 3 talks a day, I'm not able to get to all the topics in timely way. Nick says, question, antiphospholipid syndrome is associated with thrombocytopenia. Deep vein thrombosis is recurrent failed pregnancies in young women. DIC and seems to correlate with the AstraZeneca clotting incidents. Missing link. Maybe. But what I think, so I'm going to just provide my opinion. This is my opinion. I'm not starting a rumor. I'm not sure if this is the right mechanism. I think AstraZeneca's vaccine, when given and the immune system is responding, it is creating antibodies that are attacking the platelets. So that means that in AstraZeneca's DNA for the spike protein, they're creating some sort of a spike protein epitope, which is cross-matching with platelet surface. And when the platelets are going under attack, that is where the thrombocytopenia and the thrombosis, if the injured platelets are settling on the endothelium, is happening. My thought, maybe I'm wrong. Zelena says, question, I just finished watching Dr. Yo's interview with Adam Gartner. Can you please address what you think of Adam's opinion? Did Dr. Yo not do it? I didn't even hear. I see. Got it. Okay, I'm just looking through to see the questions. So Monique says, do you think someone with high blood pressure should take Janssen vaccine, or should they better take some other vaccine? It depends what is the reason for the hypertension. Is that idiopathic hypertension or essential hypertension that many of the 80% of the patients have? That is, they don't have a reason, but they are hypertensive. Or is there some underlying pathology? And then is that something that is tested? If there is a pathology, is that tested? All of these vaccines have been used in trials on people with comorbidities, including cardiovascular systems, which includes hypertension, and there has been no issue. So I don't think there is a contraindication published in those vaccines for these situations. This is very, very interesting. So George Smooth says, Dr. Bean, I read sanitized nasal spray was approved for emergency use in Israel and New Zealand. That is very interesting. I loved the idea of that nasal spray. And some folks said, why are you talking specifically about sanitize and not other nasal sprays? Even sanitize was, somebody wrote it here, and I went and I saw it. So we can talk about others too. So Vidur Talrija says, hi, Dr. Bean, I got my first AstraZeneca jab and felt really bad, symptoms 24 hours later, but now 3 days later, I'm feeling much better. Excellent, good to know. And then on this topic, if William is here, William, hopefully you are doing better. How is your health? Okay, more questions here. Mike says, does COVID cause permanent organ damage? It can cause permanent organ damage. For example, the people whose lungs get damaged and the baby lung syndrome occurs after they have been damaged by COVID and then the ventilator, they would become many of them would become oxygen dependent forever. The patient who was my friend's brother in New York, who was on ventilator, he had actually recovered a lot. Eventually, he passed away, but he had recovered. He had become conscious. He used to communicate by writing things, but uh, he was not able to get off of ventilator because of the lung damage that was permanent, and his lungs were so hard now that without ventilators force he was not able to breathe, plus he was weak as well. So he had to, if he had survived, he had to go to rehabilitation where they would have helped as much as possible, and then he would still have to be on oxygen forever. So yes, there are possible long duration after effects. Same is true for pancreas or for kidney. So it really depends what kind of damage and how much damage occurred. Simple Steve says, why can a very old person have minor COVID symptoms versus a young person who dies from getting the virus? Does it have anything to do with the MSC1 protein and immunity response? Yeah, so MSC1 is really, so let's talk about that for a second. I hope I remember the overall bigger question, but let me explain the MHC1 versus 2. So what happens is our body, from an immune system's point of view, from an antigen presentation point of view, can be divided into three kind of cells. Nucleated cells, meaning they have a nucleus, and common average cells. Not, let me put the other ones here. Then nucleated cells, they also have a nucleus, but they are professional antigen presenting cell, or professional APCs, antigen presenting cell. They are also nucleated. And then non-nucleated cells, for example, red blood cells don't have a nucleus. For example, platelet are technically not cells. They are pinched off small pieces from megakaryocytes, which are cells. But let's say platelet, just for us to be flexible, are kind of cells. They also don't have a nucleus. So the nucleated cells that are not antigen presenting cells, that means these cells, for example, are muscle cells, are fibroblast, are kidney cells, liver cells, all cells other than dendritic cells, macrophages, and B cells. These three kind of cells are called professional antigen presenting cells. All cells that are nucleated can present an antigen. So that means these cells can present antigens as well. However, the average common cells, they present an antigen on MHC1. That is nothing but a protein arm on which they load the piece of antigen and present it on the outside. MHC1 would always combine with the cytotoxic T cell, so CD8 cell. MSC1 never combines with T helper cell. That is the only restriction here. On the other hand, a professional antigen presenting cell presents the antigen on MSC2. And that MSC2 and antigen can then be connected with helper cells, T helper cells, or these are called CD4 positive cells, which we know the remaining pathway. Now, the professional antigen presenting cells, macrophages, dendritic cells, B cells, are also nucleated common cells as well. So a COP in the society is a common person as well, and they are a COP too. So when you look at this cell as a common cell, it can present antigen on MSC1 as well. So when this macrophage or dendritic cell or B cell actually becomes infected by something, it can present its antigen on MSC1. And when it has eaten up an antigen deliberately, it has arrested someone, then it can present that antigen on MSC2. So that is the specialization between them. Other than this, The mechanistic difference is that MSC1 triggers CD8 cells and MSC2 triggers CD4 cells, which can then trigger B cells or T cells, CD8 cells. So that is the basic difference. So now if I go back to your question here, why can a very old... I'm so sorry. I was not even sharing my screen and just speaking since then. Apologies. I'm sure many people would have been saying. So back here, this is the nucleated cell, and this is also a nucleated cell. This is antigen presenting cell. That means this could be a macrophage, a dendritic cell, or a B cell. This one is any cell, including macrophage, B cell, and dendritic cell. A common nucleated cell presents itself or antigen on MHC1. Professional antigen presenting cell presents the antigen on MHC2. MHC2 would then cause the CD4 helper cell to be triggered, and then T helper 1, T helper 2 pathway may engage, and that would cause plasma cell or the CD8 T cell to be activated. On the other hand, a normal common nucleated cell can only present through MHC1, and that would only trigger CD8 positive. These professional antigen presenting cells can present through MSC2 or MSC1. So now if I go back to your question, then does it have anything to do with these? No. The MSC1 and MSC2 system becomes active in everyone who has an immune system, healthy or less healthy, but these cells would be activated, or these presentations will be activated everywhere. So apologies that I was not sharing at that time. Mike says, could you please use different colors? Mike, is this the red color? I thought was pretty kind of prominent. Happy to use different colors if somehow there is an issue. Nick says that Dr. Yo and Adam Gartner suggested P1 variant can deactivate MHC1 on APCs so that the peptides cannot be presented, thus making them invisible to CD8 cells. So I like them both, but from what you are writing here, if I respond to that, then look, here is an APC, antigen presenting cell. This could be a dendritic cell or a macrophage, and it can present on MHC2 or on MHC1, correct? Now, it's not just the APCs MHC1 that are important. These are really not that important. And the reason for that is, so to me, it seems like a lack of understanding of the mechanism. The reason for that is that MHC1 presentation is really more important for other cells than APCs. MHC1 presentations is important for APC if APC itself is sick. So let's look at the mechanism in this light that you said, and I hope the colors are fine. So let's do this. Let's say here is an average cell, non-antigen presenting cell. And again, APC itself, every cell, every nucleated cell is an APC cell, antigen presenting cell. So antigen presenting cells need to be classified in two ways: professional antigen presenting cells and non-professional antigen presenting cell. So let's say this is a non-professional antigen presenting cell. So what would that be? For example, a lung epithelium cell that is infected by this cell can present the antigen only on MHC1. On the other hand, let's say dendritic cell is a nucleated cell, so it can present things on MHC1, and it can present them on MHC2. So if we said that the virus turns off all MHC1s everywhere. What we are saying is that all nucleated cells, that is muscle cell, that would mean macrophages, dendritic cells, fibroblasts, epithelial cells, endothelial cells, every cell. And if you're saying that every cell's MHC1 would become stopped from working, then forget about the virus being more infected. Just think the person is going to die. MHC1, if that is turned off everywhere, the body just cannot sustain that large amount of inability to work with the immune system. And body is presenting antigens, the cells are presenting antigen to immune system all the time. It's not just the COVID. Even now that we guys are sitting, we have so many viruses and bacteria and unwanted debris and cancer type cells or productions of those that are continuously being presented. And immune system is continuously working with them and kind of clearing them. So to go back here to, let's see, the message. And again, there is no ding here to Adam or Dr. Yo. They both are good friends of mine. P1 variant can deactivate MSC1 on APC so that the peptides cannot be presented, thus making them invisible to CD8 cells, making the virus more virulent. So more clarity here. So let's say the virus arrives. Here is the virus. It is picked up by a dendritic cell, a professional antigen presenting cell. It is going to present it on MHC2, a small part of that viral protein peptide. Viral peptide is nothing but a piece of virus. A protein peptide is called a protein, right? So small piece of the virus is now presented here. Then what happens is, keep an eye on, in this discussion, where the CD8 cells or MHC1's role come in. So far, no role. I'm not talking about MHC here. Why? Because this cell is not infected. It actually deliberately, by intention, picked up the virus. So it is presenting it on MHC2. This is its job, to pick up weird things, just like kids pick up all kinds of things and eat them. So this thing's job is to phagocytose it. And how does it find it? It can find that by PAMP or DAMP or various kind of toll-like receptors. So it has specific receptors to pick up pathogen with patrons and eat them up, and then crush them and then show them outside on MHC2. Once it is shown on MHC2, then we know that the naive T cell would engage. Naive T helper cell will engage. This engagement will cause either, we know this thing, absence of IL-12 or presence of IL-4 will cause T helper 2 pathway to become engaged, and that would cause the B cell to become a plasma cell. Nothing new. These are the discussions we've been doing for a year. Then here is the important part. If T helper 1 pathway is engaged, if this pathway is engaged, then what would happen is that T helper 1 would cause the interleukin 2 to be released, which would now comes the cytotoxic T cell. So this is a cytotoxic T cell. Cytotoxic T cell. This is going to now connect with MSC1 in a second. So cytotoxic T cell becomes activated. So think about it with me for a second. If interleukin 2 is given, and that activates all cytotoxic cells in the vicinity, then those cytotoxic cells would just start destroying everything. But that does not happen. The cells that are infected by the virus, now there is a difference in cells that have eaten up a virus. These are professional antigen presenting cells, macrophages, dendritic cells, versus cells that have become infected. So let's put an epithelial cell here, lung epithelial cell, and infect it with the virus. Now this cell will be presenting that piece of the virus on its MHC1. This cell is presenting it on MHC1. Now the CD8 cells, T cell receptor would bind here. So basically what is going to be happening is, this pair was already there. How was that there? So forget about this whole mechanism for a second. Forget that, it doesn't exist. Just imagine we had the infection, and when the infection occurred, the lungs epithelium, or the surface cells of the lung, got infected by the virus. And those epithelial cells are not professional antigen presenting cells, they're general antigen presenting cells. They're nucleated, so they are going to present the antigen on MHC1. This is this MHC1. When they are presenting it on MHC1, some cytotoxic T cell in the vicinity will actually bind with them. But there is nothing more happening. This is like if you are in a game and you ask people to stand up and stand in pairs and hold each other's hands. But that's about it. Don't do anything else. Just stand in pairs, hold each other's hands. This is what's happening. They're standing in pairs and they're just holding each other's hands. Then bring the virus to MHC2 side and activate this path. If now this guy, this T cell that was standing there holding the hand of an average cell, if you pour interleukin 2 on it, then this will become active. So that means if there is another CD8 cell standing here who's not holding anybody's hand, and you say go, this is not going to do anything. This guy would become active, and when it would become active, it would attack this cell and kill it. That is the role of MHC1. Now, MHC1's role with the macrophages or dendritic cell is very limited. That is only when these guys, it is like a cop who is off duty and is involved in a brawl and is average commoner. So going back to the question here, variant P1 on APC, so if I now kind of put this up, P1 variant can deactivate MHC on APCs so that peptide cannot be presented, thus making them invisible to CD8 cells. And then, so what we are saying is this. What we are saying is that somehow the P1 variant is capable of getting into a cell, then preventing its MHC1 from presenting outside. And this couple will not occur. And when this would not happen, then activating the CD8 cells would do nothing. If this happens, the result is not actually going to be, so I'm going to go with this one. If the whole body's MHC1 is just not working, we just have a lot of problem now. The problem is not that the infection is going to increase. Do you know that this would actually reduce the damage? Here is why the damage would reduce. When MHC1 is presenting and the cytotoxic cell is connecting, this cytotoxic cell is going to kill this cell. That would cause the cell debris to come out, and then that would start the cycle of inflammation. Yes, it will kill the cell to contain the infection, but whatever viruses are there, they are going to come out. And then they're going to go into the other one. Maybe some of them are formed, some of them are not fully formed. So for me, that would be an interesting thing to observe, that whole body's MHC1 systems are not working. That would create so many kinds of strange abnormalities, not the abnormalities that we are seeing. So I'll look into the studies and see what is going on. But this mechanism of CD8 doesn't make too much sense to me. Maybe there is some logic behind it. Sorry for a long explanation. Mike says, hit the like button. Yes, please. And then maybe there is a study that they may have been banking that information on. So let's see. P1 strain binds with MHC1. So what was the comment? To disable its engagement with cytotoxic T cells. I'm just making up. Immune evasion of natural killer cells. That's natural killer cell. The molecular megabyte natural killer cell. So we want to do SARS-CoV-2 MHC1. Let's see that. Then expand it to, did they have a study that they were looking at P1 variant? So maybe this is the one. So let's see. This study came out on 4th March. So pretty recent this month. Abstracted CD8 T cell immunity to SARS-CoV-2 has been implicated in COVID-19 severity and virus control. Here we identified non-synonymous mutations in MHC1 restricted CD8 T cells epitopes. MHC1 restricted CD8, all CD8s are MHC1. After deep sequencing of 747 SARS-CoV-2 virus isolates, mutant peptide exhibited diminished or abrogated MHC1 binding in a cell-free in vitro assay. Okay, reduced MHC1 binding of the mutant peptides was associated with decreased proliferation, okay, interferon gamma production, and cytotoxic activity of CD8 cells. So I can explain this mechanism. I'm sorry, Nick, when I read your mechanism, that was a little bit different. So I can explain what they are saying over here. So interferon gamma production and this single cell RNA sequencing of ex vivo expanded tetramer sorted CD8 plus T cells from COVID-19 patient further revealed qualitative difference in the transcriptional response to mutant peptide. Our findings highlight the capacity of SARS-CoV-2 to subvert CD8 T cell surveillance. Okay, so now let me explain what they're talking about. Keep the same pair in your mind. What they're saying is the function of a average cell is to present the antigen. And here, let's say we have this SARS-CoV-2. So this is a normal average epithelial cell. This is not a professional antigen presenting cell. This cell is going to present antigen on MHC1. They're saying that the SARS-CoV-2 here, so if you see here, SARS-CoV-2, what is the mutation they're looking at? Immunity SARS-CoV-2. Here we identified non-synonymous mutations in MHC1 restricted CD8 T cell epitope. So what they're saying is, and this would actually not be a very interesting study. So let me explain why. What they're saying is, on this virus, there is some epitope. So let's highlight this part of the virus. They're saying epitope is part of the virus that can bind with something in our body. So let's say not the binding with ACE2, but binding with let's say antibodies, or binding with MHC1, or binding with other things for interaction. So let's say this part here is an epitope of the virus, which when we chop up this virus, when we know that we pick up the viruses and we break them down into smaller pieces. And so we chop them up. So let's say here, this is this pieces of spike proteins, and this is the pieces of the body of the virus, and then the RNA of the virus, and then the M protein of the virus, and then the N protein of the virus. So all of the virus, 29,000 amino acids of the virus, and usually epitope is made up of anywhere from 6 amino acids to 12 amino acids. So let's say 7 amino acids. So 29,000 amino acid divided by 7, not all become epitopes, but let's say there are epitopes in there. So we lay out the virus in front of us and we have chopped it up. Then what we do is we load pieces of this on MHC1. So what we do is we take a tiny piece from here, we load it on MHC1, and then we present MHC1 on the surface. So we take this tiny piece and present it here. And then we hope that CD8 cell would engage here, that CD8 cell would also know to bind here with this antigen. CD8 cells would not just willy-nilly bind with any cell. They would bind with a cell that has an MHC1 presenting the epitope or a piece of antigen, and the CD8 cells own, so this is a CD8 positive cell, cytotoxic T cell. CD8 cells own binding site should also bind here, right? So back here, severity, here we identified non-synonymous mutations. So non-synonymous means there are mutations on the surface of this surface or various parts of this virus, which have changed these antigens, or these small epitopes, pieces. Mutations in MHC1 restricted CD8 T cell epitope. So they are saying this part here, that is going to bind with here, with the CD8. This part in the virus is changed. So mutant peptide exhibited diminished the or abrogates MHC1 binding in a cell-free in vitro assay. Now they're saying that this MHC binding is not happening because the virus has changed some of its epitopes. And because of that, when the MHC1 is presenting, or it is not even presenting because there is no binding that is happening here. The problem with this one is that, let's say there is one change here, one change here, one change here, which allows the MHC not to bind there. But there are 29,000, I have to look at the results. Give me 1 second. I just want to do this quick calculation. 29,000 amino acid divided by 7. There are 4,142 epitopes. And out of those 10 epitopes, 200, 300 epitopes are changed, that they cannot be loaded on MSC1 anymore. Then the others would still be loaded. So now, what are they? So let me actually explain the remaining part of it. Let's assume that they're not loaded. That means this interaction will not happen. When this interaction will not happen, normally when this interaction happens, then this CD8 cell will release interferon gamma. This interferon gamma, so if I put the remaining system here, let's say this was a dendritic cell, naive T cell, then T helper 1 cell, then CD8, T helper 2 cell, then B cell, plasma cell, correct? This interferon gamma production activates the innate arm, or I shouldn't say activate, amplifies the innate arm. This is called IL-12 interferon gamma axis, because this side, the innate arm, is producing IL-12. That is why we went this route. And then in response, this route is producing interferon gamma. So they both are amplifying each other. So they are saying, the scientists are saying that they saw that if enough MSC1 are not loaded and they are not activating enough CD8 cells, then enough interferon gamma is not produced, which ideally should mean that enough innate arm is not activating. So let's see what are they saying here. So reduced MHC1 binding of the mutant peptide was associated with decreased proliferation. Proliferation means increase in number of cells. So when a T cell is connected here and you connect it with these guys, then it would start making its copies. It happens with the B cells too. That is called proliferation. So where are we? With decreased proliferation, interferon gamma production and cytotoxic activity of CD8 cells isolated from HLA-matched COVID-19 patients. Single-cell RNA sequencing of ex vivo expanded tetramer-sorted CD8 cells from COVID-19 patients further revealed qualitative differences in the transcription response to mutant peptide. Our findings highlight the capacity of this to subvert T cell surveillance through point mutations in MHC1 restricted viral epitopes. So they're saying that we are seeing that the virus is able to escape this presentation and activate the CD8 cells, which in turn will activate interferon gamma, which in turn would cause the innate arm to become active. So that would reduce the response of the immune system. Couple of things I want to see their results as well. Couple of things. Number one, this pathway is not activated in everyone. It is usually activated. This pathway is activated more, the antibody. That is why the cytokine storms too. This pathway is usually activated less. And normally when it is activated less, it is going to cause less symptoms as well. So still, this is a pathway. I want to see the results. Sorry. Okay. All right. So in the results, they have not given a summary. They put the whole thing in here. The presented data, remember this, that this is not an in vivo, this is in vitro and outside of the cell. So it's not even the cell's mechanics that are engaging. The presented data demonstrate that SARS-CoV-2 may evade CTL surveillance through mutations in viral epitope, which lead to reduced peptide MSC1 binding and quantitatively altered CL response. Okay, so again, what they're saying is this, what I just explained. Now, how much is that happening? I would look into this a little more. Yeah, this is what I was thinking they would have written, or something like this, because this is a study not done even in vitro. This is a study not done with the cells to be done this way. They actually took out the epitope and they took out the MSC and they tried to bind them. That usually material and design, collection and processing, sample collection, virus sequencing, mutation, MSC1. See this part, MSC1 binding protection. To predict the binding strength of the wild type and mutant peptide, net MHK CPAN 41 was used. Okay, I get it. So in theory, this is possible. What they're saying is, we are seeing that this virus has a potential with some changes on it, that these areas will not load on MHC1 and they would evade this. But this is still, the study is done in vitro plus in a simulation. They have not seen this in an actual cell. They're saying that this kind of a thing is then seen in the COVID-19 cells sequencing. So maybe this is matching. I think it is not too worrisome at this time, but I'll look more into it. It doesn't look like they have actually seen this mechanism in the people. Did I get derailed and go into the rabbit hole? My apologies for that. 7 o'clock. So how are things here? Did you just start doing your own little chats and said whatever Mubin is saying can continue to say? So Denise says, but the CD8 arm is what Dr. Patterson believes is the key in long haulers. I have to see that what is the theory. Again, as you just saw that sometimes so Janet says, Dr. Bean wants his channel to survive, and so do I. But at some point, we are rearranging the deck chairs. Get my drift? So, Janet, are you saying that rearranging of the deck chairs, we would do other discussions? My channel was there before as well. I was just more working with the healthcare professionals and medical students and nursing students. And to be very honest, I used to make more revenue when I was working with healthcare professionals and students because my whole work was related to their needs. This is just this 1 year that I deviated from there. And my channel was not very big before as well because I was not actually a YouTuber. I was putting my content on Drbeen and we were selling it from there. So we'll continue to do that. And if, for God forbid, I mean, I cannot say with guarantee, if my business closes down, then it closes down. But YouTube is not the primary outcome for me. I have been fortunate that I got this opportunity to serve during the last 1 year. In this time, people have become upset, the healthcare professionals and students, that I haven't done a lot of things for them. So hopefully pandemic ends soon. So either we would then use this channel to do more discussions around aging, cancer, hypertension, diabetes, and other things that can serve you. And if the appetite is not there for that, then I would just continue to serve healthcare folks before, and hopefully I'll be okay. Absolutely. Thank you. Thank you. Thank you, Christine. Okay. So Colin says, would it not make sense to test everyone for antibodies before giving a vax so that data would give a more complete picture in future? And yes, this is a question that has been asked many, many times. And I think it is logistics. It is just them not putting that as part of the process as well. And otherwise, I would love it. Saber Steve says, hit the like button, smash the bell. Yes. Machiavelli says, I was with you until you said, let's begin. So Sheikh Maniac says, I think you're missing the fact of CD8 T cells energy that is caused by galectin. So the thing is this, the CD8 T cell energy is only needed when we do not want to respond to something. This study is saying that the change in the virus is reducing CD8 response, and that is bad. This is what the study is saying. So why would we then try to further stop the CD8 cells? Happy to go down the rabbit hole. Dr. Bean is very interesting. Thank you very much. When I go down these rabbit holes of medical concepts, I just lose it that I have an audience with me as well. I just go there. So LG says, is there any new virus mutation which is not covered with the current vaccines? There may be that we do not know yet, but not that is prominently discussed or presented. Michelle says, since I did not develop antibodies and survived COVID with pneumonia, I'm assuming the epitope thing did not affect my innate arm. So the epitopes are always there. The reason for that is, you're correct in saying that it may not have affected you. And are you sure that you had, for example, P1? They are kind of specifying it to be P1. But what happens is the epitope or the presentation of the virus, this presentation always has to be done for any kind of immune responses. So epitopes are there, antigens are there. this may be that the effect of this whole system was not there for you. Trevor says, do you still think that the end of pandemic is months away? Yes. I actually feel that a couple of months later, we'll be kind of done with it. Actually, if you see, people have started moving about. Many countries' cases are going down. There are some countries where cases are going up as well. It was sad for me. And then the vaccines are going out very fast as well. So I think that we'll be out of it very soon. There is one more clue, even for our discussions. You might actually see that uh, the ask to talk more about diabetes or others is increasing now, because I think majority of the concepts are understood, majority of the ways and mechanics are understood, the cases are going down. So the scare of the pandemic is kind of behind us now. So we are moving out. Romana says, I've been fan of your work and subscribed to Lifetime Access a while ago when I needed extra study material for my work. Now I enjoy your talks as well and find them well structured, even for general public. Thank you very much. Sepa Steve says, any updates on COVID around the world? How about Italy and France? So how are they doing? Let's see. Let's see how they are doing. So if we go to Worldometer, as usual, start with Israel, and very nice. Cases are down, active cases are down, and I'm sure that deaths are also down. Not as fast, but still down. Now, if we look at, let's say, France, 4 million cases. What is this? France, they are actually increasing again. Active cases going up. Deaths going up as well. So there is something going on in France. I have to research. And how about Italy? Oh, wow. Look at this. Third wave, first wave, second wave, and they are stuck in the third wave. Active cases are not as high, but still high. And deaths are following as well. So not good. Not good. UK did very well. How is UK still going? So look at that. I admire UK. They were really getting beaten up before, and here this is very good. Active cases going down, and I'm sure that, yes, look at these numbers. So UK doing good, and that is lockdown. How about USA? US, not USA. The US, not the best, and we, at least in the US, are not very careful, not a lot careful, but still this has gone down a lot. I don't think that this is something to do with the lockdown. Yes, it is something to do with more mask wearing awareness. I think it is vaccinations as well. I think it is herd immunity as well. I think it is people kind of caring for themselves, I think. But you could not have this by the way we are open as well. And these numbers are going down too. So good numbers. Wow, that is sad. So France is a mess. I see you cannot accept more. Sweden, let's see Sweden. Sweden is a very interesting one. We did a few talks in the beginning. Let's see. Sweden. So here, not the best. So they had gone up to 11,000. So let's do an average. Let's do 7 days average. So they were 5,000 ish, and they are, wow, 3,000. So less, but not a lot less. This is actually not a good trend. They are actually rising again. And how about deaths? So the deaths had been going down, and I think with this new rise, there would be deaths that would follow in another 6-8 weeks. That's not good. What happened to Sweden? So let's see Canada. Canada. Oh wow. They're also trending upwards. Active cases are down, but they are once again started going up. That's not good. Number of deaths are down, but I think with the latest trend, the deaths would follow a little later with this trend. This is not good. What happened? Poland is bad. Let's see. Poland. Oh wow. Almost a wave like before. Deaths also following. What is their vaccination status? Poland vaccination. Do we have a total vaccination? So vaccination in Poland began on December 28, 2020, with 8.5% of the Polish population vaccinated with at least one dose as of March 22. 8.5. And the number of cases in Poland, so if I go here, because they would be part of the herd immunity as well. So coronavirus cases 2 million, recovered 1.6. Let's say all of them, 2 million, are part of herd immunity. What is Poland's population? Alexa, what is Poland's population?
In 2020, the population of Poland was 37.8 million people.
So 37.8, 38 million people, 2 million here, and then 8.5% here. So 8.5% of 40 million. So 3.2. So about 12, 13 million, 12, 13%. Okay, so not too high. And the cases are just going up. Poland is not doing good. Samina says, I appreciate your presentation and your respect for medical science. Thank you very much. Ruby Zaret says, Canada has variants in key cities and must fight to contain them, but people are COVID tired and want out spreading the variants. It is summer as well, that summer or the warm time starting. So Susan says, we had the UK variant hit Regina Sask last week. They had a day where there were 300 presumptive cases. City has a pop of about 270,000. So, hey Jenna, how are you? How are you doing? How is your health? Czech Republic, my country birth, is not doing that well either. Czech Republic, I'll have to go and select it from here. Here. I'm just going to look for Republic. Dominican Republic. Okay, so CZEZ. Here. So here 1.47. And yes, you're correct. And the active cases are just going up. The most now, it is at the peak now. And the deaths are following as well. What's going on? Are they not vaccinating? Are they not caring? This is sad to see countries getting stuck like this. Andre says, didn't hear about Pakistan. Let's look at that. So if I go here, Pakistan. I heard that Pakistan's prime minister developed the infection as well. So yes, so there is a third wave developing. Cases are going up again, not the highest as they were before, but going up. And I know that in Pakistan, they're using ivermectin very commonly. Death rate is increasing as well. This is not nice. Look at China. Hubert says, look at China. That's a good one. China. Are they reporting correctly? What? Coronavirus cases 90,000? No deaths. Active cases down to 165. Nothing. What has China done to reach there? Is it lack of data, or is it really that they are the only ones who have controlled it and the rest of the world doesn't know what to do? Doug says rock solid data from CCP. So, John, they are using ivermectin, but still, it is my statement commonly. What I don't know is 100%, 90%, 50%. I know that they had opened up the whole society and people started going back to schools, and then they started exams, and they just opened up everything. And now they have closed things again. Bonk Bonk says, would you go on Joe Rogan podcast to spread awareness of vitamin D and ivermectin? Yes, if he invites me. 32 waves later. Sipper Steve says, read today that only 1.2% of the world's population has been vaccinated. We have a long way to go. Agreed. But hopefully we are vaccinating the most at-risk population, and so that that disproportionate number of deaths would reduce. I wish the whole thing stops. Lisa says, if you believe numbers in China, bridge to sell you in Arizona. So Carlos says, why do the poor countries in Africa not have catastrophic results? Don't know. Are they able to provide the data, or they really don't have it because they use things like hydroxy or ivermectin, or there is something else? So don't know. Marco Kane says, Imran Khan has been Prime Minister of Pakistan for a while now. See, there is a life after cricket. Yes, He used to be a very popular cricketer. Okay, so Samina says Bangladesh. So let's see Bangladesh. Bangladesh. So Samina, unfortunately, there is another wave appearing. Active cases are on the lower side, but still increasing now. And there is a wave appearing in the number of deaths as well. So on a day-to-day basis, the number of deaths are lower, but still they're increasing. Doug says Pitcairn Island. I heard this for the first time. Doug, is that a correct name? Jody says, my good friend lives in China. They all locked down for like 3 months. They think the US is kind of nuts. We were doing much worse than where we are now. So Texas Mag, no, I have to read that, but I heard about this, that there are infections occurring in the vaccinated residents. Now the question is, was it because of a variant, or was it the immune system not responding well enough, or something else? So Mel Bean says, can taking the BCG vaccine help with the COVID immunity? So we did do a discussion that in theory it did help. And then there were some small studies that showed it helped. But then there were some larger studies that did not show that benefit. Michael Stalwart says, Africa has Artemisia annua T. That's why Artemisia annua is parent of HCQ. Yeah, so hydroxy. But is that it? Is the hydroxy the only solution? Cool. So John Scott says, study titled SARS-CoV-2 binds platelet ACE2 to enhance thrombosis in COVID-19. And it is possible. We have seen thrombosis. And that is what I was conjecturing, that it is possible that thrombosis. So in this case of the vaccine, the antibody is binding there. But we talked about it in the past as well, that in hypercoagulable states, wherever the ACE2 are in the blood vascular system, we didn't specifically talk about platelets ACE2. But that is an interesting one. Maybe we should discuss it. So Rima says, I'm worried about the third wave. It is possible now that with the variants, let's say. John Snyder says, Israel is seeing 12% or so in fully vaccinated populations. 12% what? So let's see Israel's. So if we go for vaccine tracker, Bloomberg vaccine tracker, 468 million doses have been administered, 500 million, not a lot. Now let's see Israel. So Israel, population 9.79 million. Enough for percent of people, 54%. First dose received by 57, fully vaccinated 50%. So almost half the population is vaccinated. Israel should reach a point of saying no more infections, or are not of one or lesser. So if I go to Israel, and then So new cases are less, of course, but not down to zero. What were their higher? So in the higher times, if I turn on 7 days moving average, higher time 8,000, 7,000. So if we take an average here, this line about 5,000 per day. From there, they are now dropping to 1,000. So 5 times reduction, which is good. And look at the active cases that are low as well. So I guess my hope is they become zero, and that is the result of vaccination. And that's not what we are seeing yet. Mask, yes, mask is important. Cool. Jenna says, are they reporting the positive cases in those that had vaccine, or is this separate reporting? Um, Jenna, are you talking about Israel? I think they are. This is just general reporting, including vaccinated or not. Um, Brazil, record number of both deaths and cases today. Really? We saw Brazil yesterday, and they were not doing that great. Yesterday or last time. Oh wow. They are. It looks like they are now becoming a bigger wave. Look at the active cases, 1.2 million, and number of deaths increasing. So today, 3,158. Yes, that is the highest line here. And it doesn't show today to be the highest number, 85,000 cases. There have been 90,000 before, so maybe there is a different number for today, but that's a lot. That's a lot. Samina says, please show us the Krona status of Bangladesh. So, Samina, we just saw it. Let me show it again. Bangladesh. So, there is a new wave that is starting. If I go for 7 days average, it is going upwards. The cases are going upward. They are lower in general, but they are going upward. And I saw previously that the deaths are following it as well. What is Bangladesh's immune system vaccine? So 4.9 million population, about 5 million. What is this? 3% of the population is received the first dose. So not much. They're not yet protected. Vitamin D is also an important thing, yes. So Talib Hussain says, take a look at Pakistan. I just did that a few minutes ago. You're very welcome. So how about we stop for today, and we would then continue tomorrow. Tell me this. So today is what? Tuesday. Should we switch to other topics, Thursday, Friday, Saturday? Or as Janet said, do we start reducing, and how would you like it? Continue with the COVID as the developments occur, or Monday, Tuesday, Wednesday, we maybe even Thursday, we talk COVID, Then Friday, Saturday, we talk other topics. I think the open forum is kind of merged in these chit chats. So we are good, or should we do a separate open forum as well? So James Crook says alternate days. That is possible. For COVID-19 and 2 other. Okay. Samina says Bangladesh. So Samina, I have already shared Bangladesh a couple of times. Okay, Rima says stick with COVID until cases come down. 2 days, other topics. Okay. That is what I'm hearing more. Nick says mix it up. Jim says blood cancers. Dr. B, nervous about variants third wave, still have open forum 6 days. Yes, so we'll continue. We can do this. We can do this thing that we can have, let's say, 3 or 4 days COVID, then 2 days for other topics, and then on those 2 days, we can still do the open forums. Okay, cool. So let's do this. Today is Tuesday, Wednesday, Thursday, we'll talk COVID. And then Friday, Saturday, we'll continue with diabetes, and then we'll go to other things. I think we should create a registry of the topics. For example, Jim just said blood cancers. We should start capturing them. Yes. Saturday Zoom. So how about Friday Zoom. So Monday, Tuesday, Wednesday, COVID. Thursday, we do something else. Friday Zoom. Saturday, we do something else as well. Okay, we'll play it by the ear and we'll see how to adjust it. Yes, Friday Zoom will continue. If you like to continue to do Zoom. I would love to see France. I heard that France is a celebrity, and that is why France was wearing a mask as well to hide their celebrity status. Okay, cool. So you are very welcome. France is here. France says, Dr. Bean, John has a great suggestion. Actually, you could pull the long COVID article from Nature, then cover the diseases it causes and how to treat them. That's a very good idea. That is a beautiful idea, to actually still be talking about other things, but have a branch back into the COVID. So, John, can you send me the link? Maybe you can tweet it to me. So Janine says, Dr. Bean, pick my question. So let me go try to find this question, Janine. Going up. Thing is my hair. So Janine says, yes, always COVID, but talk about long haulers, neurological and kidney issues, vaccine adverse effect. Okay. Was this the one, Janine, or there was a question as well? So I'm seeing same comment. So maybe this was the one. Got it. Yes, you are making us all celebrities. You are celebrities. Think about it. Without you, I'm nowhere. So you are celebrities. Okay, so Zoom link. This time I'll do better. I will put the link in the description, plus at the time of the chat on Friday in the live chat as well. So it will be present in both places. And I believe my Zoom license allows 100 people. The first one had maximum at one time was 74. There were some folks who would come in and then leave. And so maximum we hit was 74. Last time, similar number. So I think 100 covers it. If for some reason that we started becoming more than 100, then I would up the license. Cool. Where is Luffy? Luffy? Where is Luffy? He is somewhere, but he is very quiet today. Yes. So Yashpal says, will we do diabetes again? Yes, we'll continue with diabetes. That is a very important topic. We're not finished with it yet. We just started. So very good. Thank you very much. Please like, subscribe, and share. And there are 3 links in the description. One is to buy me a coffee. Other one is for our Patreon. And the third one is to support this work in general. So thank you very much for your attention, for your time, for hanging out with me. And I would see you tomorrow. Bye-bye.